Scientific poster presenting a case study of suspected Caesarean Scar Ectopic pregnancy, discussing ultrasound, the legalities, differential diagnosis, management, issues around colour flow Doppler, and alternative imaging. Caesarean Scar Ectopic is a pregnancy that is implanted at the site of a previous C-section scar. The incidence of Caesarean Scar Ectopic is rising, and misdiagnosis can lead to increased maternal morbidity and mortality. The main symptoms that a woman may present with in an early pregnancy unit are vaginal bleeding and/or abdominal cramping, and this can be concerning for the patient. However, the sonographer should observe the patient for signs outlined on the poster. The Society of Radiographers, BEMUS, NICE, and RCN highlight key areas for sonographers to consider: patient dignity and confidentiality. The Consortium of Accreditation of Sonographic Education requires students to follow a code of conduct. They recommend that students are supervised by a qualified sonographer and seek advice when they are uncertain, that students explain their role when gaining consent. Guidance from NICE advise women with suspected ectopic pregnancy have an ultrasound scan, preferably a transvaginal as a gold standard, or transabdominal to determine the viability of a pregnancy. There is an emphasis on the importance of informed consent prior to all examinations. Should the woman decline a vaginal scan, she should be offered an abdominal scan and be made aware of the limitations. By explaining the procedure of the transvaginal scan, this may alleviate the patient's concerns. To ensure the safety of both the patient and the staff member, a chaperone must be offered during an examination, though this may be difficult due to the lack of availability of staff members. Communication with the patient is vital. Therefore, if any difficulties are anticipated, such as language, an interpreter should be arranged, and it is recommended that healthcare professionals be trained in breaking bad news and communicating sensitively. Guidance around ectopic pregnancies mainly focus on tubal ectopics, but with incidence of Caesarean scar ectopics on the rise, the guidance should be updated. The RCOG recommend all non-emergency scans of suspected Caesarean scar ectopics are referred to a regional centre to confirm the diagnosis. Additionally, NICE state that women must be seen within a 24-hour period. This presents difficulties as it may put pressure on services with an increased number of scans performed by a growing workforce deficit. This may make access to these services difficult for out-of-area patients, as transport and increased waiting may cause anxiety for patients. Case presenting a woman referred to EPAU having had an inconclusive private ultrasound scan. The woman should have been 9 weeks pregnant. Following trust policy, an abdominal scan was offered. However, a vaginal scan was performed when the contents within the sac could not be viewed. The sac revealed an irregular cystic structure at the C-section scar, with a mean sac diameter measuring 5 weeks 6 days, which could possibly represent a gestational sac. Colour flow Doppler was used to detect any increased vascularity, and the mass surrounding the cystic area appears to have infiltrated the myometrium. The ultrasound scan had an appearance of a Caesarean scar ectopic, and this is considered a high risk of rupture, especially if the myometrium thickness is less than 5 mm where the endometrium meets. Though vaginal ultrasound is a gold standard, an abdominal scan has a value in enabling a panoramic view of the uterus and its relation to the bladder. As seen on scan image 1, the uterus is empty with an endometrial thickness and a possible gestation sac at the lower uterine section, and in scan image 2, the myometrium is thin between the sac and the bladder. Figure 3 demonstrates a transvaginal scan of the same woman with an empty cervix and a possible gestation sac above it. As a result of this scan, the care pathway had changed. Figure 1 is an image of an intrauterine pregnancy designated by the arrow, and Figure 2 and 4 is a transabdominal scan of the same woman and shows a Caesarean scar ectopic and its location to the bladder, whilst also demonstrating the sac is not within the cervix or at the fundus. Though to improve the quality, the sonographer could have adjusted the focus, sector width, and magnification. Outlined on the poster are the differential diagnosis. It is important to differentiate between them because the management is considerably different. Guidance for ectopic pregnancy management states that secondary imaging, such as MRI, may be required if the ultrasound scan is inconclusive, followed by an urgent MDT discussion. Management options are surgical and medical. Expectant management is acceptable in medically stable patients. In this case, the images were reviewed by the consultant radiologist and the patient was treated with methotrexate. The scan images are sourced from the internet and serve to demonstrate the similarities in ultrasound appearances of the various potential diagnoses. Figure 7 further demonstrates the use of colour flow Doppler and how the appearance can be similar. Therefore, it is important that the sonographer be aware of these appearances and discuss the findings with another sonographer or a member of the MDT. The use of colour flow Doppler in Caesarean Scar Ectopics has many benefits. Provides a high accuracy for detecting feeder vessels, can characterize ectopic pregnancies and prevent misdiagnosis, be used to differentiate between cervical ectopic and Caesarean scar ectopic, and determine the success of treatment. However, the heating effect must be considered and weighed against the exposure and time taken to complete the examination. The sonographer must be aware of the control settings to keep thermal and mechanical indices as low as feasible, and be aware the temperature can vary between 0.1 and 1 degree, depending on the probe, setting, and focus, as the thermal effects can potentially harm a pregnancy. Though a study claims that if the thermal index is reduced to 0.5, then accurate colour flow Doppler data can be attained safely. Additionally, the World Health Organization highlighted the need for up-to-date research on new ultrasound scan technology to be carried out. Finally, the sonographer should be mindful of the ALARA principle, ensuring the scan time is limited. Figure 9 is a scan image from the case study. Though it does not show the ring of blood vessels surrounding the sac, it does demonstrate the absence of a fetal heart. Figure 10 shows a magnified classic appearance of feeder vessels surrounding the gestation sac, alongside the image of the gestation sac lower in the uterus cavity, and highlights the benefits of colour flow Doppler in diagnosis in Caesarean scar ectopic. When performing an ultrasound scan, the sonographer must ensure the ultrasound machine has an up-to-date quality assurance, and to be aware that variations in scan imaging may be due to discrepancies in equipment, settings, operator experience, and patient tolerance and BMI. For example, when using colour Doppler, the thermal index will be displayed, but there are 3 subcategories of thermal index, and only one will be displayed, but the machine will allow the user to retrieve the other 2 if required. Ultrasound machines capable of exceeding the thermal and mechanical indices of 1 are required to display both of these. Though there are many benefits to ultrasound, such as, when diagnosing a Caesarean scar ectopic, ultrasound has an accuracy of 86%, and it is cost-effective and readily available, it is not suitable for everyone and can be inconclusive. Alternative imaging modalities, such as 3D ultrasound or MRI, can offer greater detail. The table in the poster demonstrates the advantages and disadvantages. 3D ultrasound has similar advantages and disadvantages to 2D ultrasound, with the added benefit of the enhanced detail concerning the bladder involvement. With MRI, the features of Caesarean scar pregnancy are essentially the same as those described on ultrasound, though a study argued that the use of MRI did not add value to the diagnosis of the Caesarean scar ectopic, only to offer information on the infiltration and bladder involvement. Therefore, MRI should only be used when necessary. Caesarean scar ectopic pregnancy is linked with increased maternal morbidity and mortality. Therefore, with reported cases increasing, recognition of a Caesarean scar ectopic on ultrasound scan is vital. While transvaginal scanning is a gold standard, transabdominal should be considered and offered to a patient when a vaginal scan is not tolerated. When performing the ultrasound scan, the sonographer should gain consent and ensure patients understand the reason for the scan. A chaperone should be offered and documented, and the sonographer must be astute to the signs of patient discomfort. Due to the nature of this diagnosis, it is important that staff have training in communicating bad news, and if there is any anticipated communication difficulties, then the appropriate steps should be taken. With the increased instances of Caesarean scar ectopics, official guidance needs to be updated. Colour flow Doppler is important in diagnosis of Caesarean scar ectopic, however, it should be used in consideration of the heating effect. Ultrasound with colour flow Doppler is vital when confirming the location of the pregnancy in relation to the scar, to ensure the correct management plan is commenced. and should the ultrasound scan be inconclusive, then further imaging should be offered, such as 3D ultrasound and MRI if it's required. It is clear from this that the use of ultrasound imaging had a positive impact on the outcome of the patient's care.